Good afternoon, everyone. We'll get started in a few minutes. Thank you. Good afternoon, everyone. Thank you for attending our webinar today, Risk Adjustable Neurological Coding. This presentation's recording will be available on our Blue Cross Blue Shield Provider Risk Adjustment webpage. Throughout the webinar, the Q&A box will remain open for you to submit your questions. We will answer all questions pertaining to the webinar's topic in an email when we send out your CEU certificate. This presentation has been approved by the AAPC for one CEU. Please note you must attend at least 75% of the presentation in order to be awarded your certificate. After attendance has been verified, certificates will be emailed to you with your email address provided within the registration link. This presentation is intended for both physician and office staff. The information contained in this presentation and responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered on a case-by-case basis and should be supported by medical necessity and the appropriate documentation reflected within the medical record. Before we begin, I would like to take a moment to introduce our risk management team. I'm your host, Jacqueline Duncan. Our team is comprised of nurses and coders that have worked in an array of settings with many years of experience. I would like to outline some goals we have for today's webinar. Our goal is not to make you experts with risk adjustment coding, but we are hopeful that you will leave feeling more confident in finding success in our risk program. I am going to pass this on to Missy Leggett to get us started. Good afternoon, Missy.
Good afternoon. Thank you, Jackie. To kick us off, we're going to discuss some common neurological disorders, Oftentimes, providers face challenges when documenting certain neurological conditions because they are complex in nature and sometimes have overlapping symptoms. So let's begin by taking a look at Parkinson's disease. What is Parkinson's disease? Parkinson's disease is a progressive movement disorder of the nervous system that can cause nerve cells in parts of the brain to weaken, become damaged, and die. When this happens, it can cause symptoms such as tremors, stiffness, and balance problems that could cause individuals to struggle with simple, everyday tasks such as walking or talking. Most of the main symptoms of Parkinson's disease are caused by the loss of the dopamine producing neurons in the part of the brain that is responsible for smooth and intentional movement. By the time any symptoms usually appear, most people have lost around 60 to 80% of these neurons. Lewy bodies are also found in individuals with Parkinson's disease, and they are protein deposits that contribute to neuron death. The reasoning for the Lewy bodies and why they form is unknown and still being researched. Here is a list of the primary symptoms related to Parkinson's disease. Parkinson's disease usually begins on one side of the body and it eventually affects both sides, with one side being more severe than the other. The rate of progression is different for everyone as it affects different people in different ways. Tremors often begin in one's hand, but is known to appear in one's foot or jaw first as well. This is the shaking with back and forth movement. It's most obvious when the person is at rest or if they are stressed. Often it disappears when sleeping and it may improve when making intentional movement. Rigidity, known as muscle stiffness, is a resistance to movement. If movement is forced, it will result in short, jerky movements. Bradykinesia, this is the slowing down of movements. What once was quick and easy activities, such as washing their face or dressing themselves, may take much longer. Postural instability, balance problems, and changes in posture can also become a fall risk in those with Parkinson's disease. People with Parkinson's disease can also develop a Parkinsonian gait, which includes quick hurrying steps, reduced swinging in arms, start hesitation, and freezing in place while walking. Other symptoms not listed here can include mental and emotional health problems, difficulty chewing and swallowing, speech changes, bladder or bowel problems, sleep problems, dementia, and several more. Here are the 4 risk factors that affect your chances of having Parkinson's disease. Age is a factor as most people have an onset in the early to mid 60s. It is less common to see early onset Parkinson's, which occurs before the age of 50, but it does happen. Biological sex is another factor. It occurs more frequently in men than women. Heredity. If you have one or more close relatives with Parkinson's, you have an increased risk of developing it yourself. There are also several gene mutations linked to Parkinson's disease, such as LRRK2, GBA, and SNCA. Environmental exposure is the last factor, which includes those who live in rural areas with exposure to more pesticides and exposure to certain toxins, such as heavy metals and illicit drugs in rare circumstances. Unfortunately, there are no specific tests that can diagnose Parkinson's disease. A medical provider or neurologist may review the medical history with the patient, give them a thorough neurological exam, and review their symptoms, especially pertaining to movement. They may also order labs and blood work as well as imaging studies, such as MRIs, specs, to rule out other disorders. A DAT or dopamine active transporter scan can also aid in the diagnosis. There is also no cure for Parkinson's, but there are medications and surgeries that may help. Drugs that can increase dopamine, such as the most known carbidopa, levodopa, dopamine agonists like ropinirole, MAOB inhibitors like seleglene, or other drugs like antidepressants and COMT inhibitors. Surgery, such as lesion surgery, called a pallidotomy, is also an option when drug therapy is not sufficient in managing the symptoms of Parkinson's disease. It can improve primary symptoms of Parkinson's, and some studies show it can improve gait and balance. A thalamotomy can also be done to primarily reduce tremors. Deep brain stimulation is another option that is widely used as a treatment for Parkinson's disease. Lifestyle changes can also be beneficial, including having a healthy diet and physical activity, which both promote overall well being just as they would for anyone. And lastly, different varieties of therapy, including physical, speech, and occupational therapies. When it comes to documenting Parkinson's disease, the motor symptoms associated in the early stages are largely considered signs and symptoms and would not be separately reported. However, the non-motor symptoms, also common, should be documented and addressed. These are the things that we talked about earlier, such as the cognitive impairment, bladder issues, depression and anxiety, and dysphagia that could cause malnutrition. Another important note to be made is whether these symptoms are related to the Parkinson's itself or they are adverse effects from any medications and indicating any daily living issues such as bathing, dressing, and eating. These are all needed to be able to choose the correct code or codes. On October 1st, 2023, Parkinson's disease code G20 was expanded into 5 new codes. They are listed here in blue. They are broken down by using the terms dyskinesia and motor fluctuations. Dyskinesia is when the medications like levodopa cause abnormal involuntary movements. Motor fluctuations are alterations between periods marked with either a positive response to medication, which is referred to an on, and reemergence of symptoms referred to as an off. All of the diagnoses listed here from the G20 are risk adjustable. It is important to also use additional codes if they apply to identify if the patient also has dementia with behavioral, mood, or psychotic disturbances or anxiety. These codes are in the F02 groups and should be further expanded to either the fifth or sixth digit codes. Parkinsoni- Parkinsonism is a term that refers to the presentation of Parkinson-like symptoms with no exact clear cause. It includes code G20.C for Parkinsonism unspecified and G21 codes for secondary Parkinsonism. Secondary Parkinsonism is typically caused by an external agent or other condition. The codes in the table to the right are risk adjustable diagnosis codes and may require an additional code for adverse effects. Codes G2111, G2119, and G212 seen here may also require an additional code to identify the drug or external agent responsible for adverse effects. Let's do a coding scenario. A 68-year-old male presents with previously diagnosed PD with uncontrolled straightening movement of the right arm noted on physical exam. Reported worsening dyskinesia with medication use. And the plan is to change current prescription of 2 tablets of carbidopa 25 milligram, levodopa 100 milligram twice a day to a new prescription of 1 tablet, same dosage every 6 hours. The codes that should be assigned are G20.B1, Parkinson's disease with dyskinesia without mention of fluctuations. Dyskinesia is worsening with medications, but there is no mention of motor fluctuations. Next, we are going to talk about Alzheimer's disease. Alzheimer's disease is the most common form of dementia among older people. With this disease, the brain neurons stop functioning, lose connections with other neurons, and die. Alzheimer's disease onset is generally over the age of 65, and it is a leading cause of up to 70% of dementia cases. According to the CDC, minorities and women are more likely to develop Alzheimer's disease. Symptoms may include increased need for assistance with activities of daily living, including dressing, eating, and bathing. Individuals may have trouble remembering recent events, the names of people they know, and eventually they may not recognize family members. Ultimately, total care will be necessary for these patients. Currently, there is no cure for Alzheimer's disease, and symptoms can be managed with a variety of approaches, which we will discuss in a little bit during the presentation. One cause that is specific to Alzheimer's is the buildup of the beta amyloid protein. Abnormal levels of this naturally occurring protein clump together to form amyloid plaques. These collect between the neurons and they disrupt cell function, resulting in the symptoms related to Alzheimer's disease. As neurons are injured and die throughout the brain, connections between networks of neurons may break down, and many brain regions begin to shrink. By the final stages of Alzheimer's, this process called brain atrophy is widespread, causing significant loss of brain volume. Other contributors to Alzheimer's disease symptoms include neurofibrillary tangles and chronic inflammation. On this slide, you can see the early warning signs and symptoms in Alzheimer's or other dementia. The most common, of course, is memory loss and forgetting recently learned information. It can include forgetting important dates or events, repeating questions, and relying on reminder notes and family members for things that they used to handle themselves. Other symptoms include not keeping track of monthly bills, not being able to drive to a familiar location, forgetting where they are, vision changes such as judging distance, struggling with words for familiar objects, or using the wrong name, poor judgment with money, difficulty having a conversation, or becoming easily upset. While there is no single test that can determine if a person has Alzheimer's disease or another type of dementia, diagnostic tools can be combined in order to make a complete and accurate diagnosis. Medical history is a must, including any past and current medical problems and any medications currently being taken. Any family history of dementia and Alzheimer's disease will need to be noted as well. A standard physical exam and a complete neurological exam will also need to be performed to evaluate the patient for any other memory impairing or thinking disorders. Cognitive functional behavioral tests can assess changes in behavior and symptoms that can be brief or very complex and lengthy. New computerized tests and devices are being developed rapidly with new technology and software. There are a few FDA cleared tests on the market today. Depression screening and mood assessments are common to evaluate mental status. There are also brain imaging tests such as MRIs and CT scans that can help to rule out other conditions or identify potential markers found in Alzheimer's. Blood tests that may be able to predict amyloid changes in the brain are available for special cases and clinical trials, but none have been FDA approved yet. Routines are stored in long term memory. However, Alzheimer's disease usually affects short term memory initially. Routines may remain accessible into the middle stage of the disease. Calendars can be helpful with routines in patients with Alzheimer's. It reduces anxiety and makes them feel more secure. Some helpful suggestions include keeping meal times and medication times together to simplify steps, tracking the calendar daily and writing important dates such as doctor's appointments and birthdays, keeping bath time and getting dressed at the same time of day, whether morning or evening, and these will reinforce a sense of order and purpose for those with Alzheimer's or any dementia. There is a variety of medications available to treat Alzheimer's disease. Some medications, such as Aricept, reduce the buildup of the amyloid beta protein found in Alzheimer's patients to slow the progression of the disease, while others, such as Namenda, block certain substances in the brain that are linked to symptoms of Alzheimer's disease, therefore reducing the symptoms presented. Symptoms can be managed across all types of dementia using a variety of medications. Medications may be prescribed to manage sleep disturbances, anxiety, or agitation and hallucinations. Be sure to include the symptoms experienced within the Alzheimer's disease diagnosis coding as appropriate. Let's talk about some coding tips and documentation for Alzheimer's and dementia. Be sure to always spell out Alzheimer's disease as opposed to using the acronym AD to prevent confusion, especially on the first time documenting. It is very important for the care of the patient to always make sure that Alzheimer's is noted on every face-to-face encounter and details are given about history, whether it's from a caretaker or family member, any sort of behavioral disturbances that may have been witnessed or reported to that person, detail whether it is early or late onset, generally referring to the age of the patient, and the impact on the daily living for the patient and the assistance they may require day to day. Also, if the provider only documents Alzheimer's and not dementia, you should always code dementia too. It is part of having Alzheimer's disease. When coding Alzheimer's and dementia, the etiology, Alzheimer's disease, should be sequenced first. The G30 category is used to code Alzheimer's dementia. As always, it is important to code to the highest specificity known, including whether it is early onset or late onset. The manifestation, dementia, is sequenced second. Conditions such as behavioral disturbances, anxiety, and psychosis should also be captured and coded using codes from the F05 and F02 code sets. It is important to note that even if a person doesn't have an official diagnosis of Alzheimer's disease, the dementia should still be coded. Unspecified dementia, vascular dementia, and frontotemporal dementia can be used to identify dementias without a diagnosis of Alzheimer's disease and coded to include severity and behavioral disturbances when supported by documentation. Code set C55 through Z65 include codes related to social determinants of health. These challenges should be considered and documented during visits when working with this population. Interventions placed prior to an incident are ideal, and tracking these risks can help. Inability to obtain utilities and adequate food are important to know, as well as inadequate housing, environmental temperature. Social determinants of health code assignment can be based on documentation from non-provider clinicians. For example, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. Detailed interviewing of these patients and their caregivers is important when trying to keep them safe at home. Let's try another coding scenario. A 72-year-old female presents today with their daughter. The patient has a new diagnosis of late onset Alzheimer's disease by a neurologist through thorough exam and behavioral tests. Still in early mild stages, but experiencing memory loss resulting in repeated questions and not being able to drive, forgetting easily lost. Patient is experiencing depression and is worried that she will not be able to care for herself soon since she lives alone. What codes should be assigned? You would assign codes G30.1 for Alzheimer's disease with late onset, F02, A3 for dementia and other disease classified elsewhere, mild with mood disturbance, and Z60.2 for problems related to living alone. First, we would find the Alzheimer's disease in the alphabetical index, and since it was noted as late onset, we would choose the code G30.1. And when you look at this code in the tabular section, there are instructions to use additional code to identify the dementia and any behavioral disturbance related to it. We would look up dementia and other disease classified elsewhere from the F02 code set, since we already know it's specified as Alzheimer's disease. Then we would select a code for mild with mood disturbance for depression, which brings us to the code F02A3. And lastly, since there was a note related to the patient living alone and not being able to care for herself in the future, we could use the code Z060.2 to identify that the patient lives alone and that problems could arise relating to caring for themselves. Next, we will discuss multiple sclerosis, also known as MS. It is a chronic neurological and autoimmune disorder. MS affects the brain and spinal cord by attacking myelin in the central nervous system and damaging the myelin sheath, which is the material that surrounds and protects the nerve fibers. This disrupts the communication between neurons. The, The term sclerosis is a medical term for the scar-like tissue that results from the attack on the myelin. MS also damages nerve cell bodies and the nerve fibers themselves. As the disease progresses, the outermost layer of the brain, the cerebral cortex, shrinks. This is called cortical atrophy. The symptoms of MS depend on the severity of the attacks as well as the size of the plaques and their location. Let's go over some of these symptoms. When it comes to MS, vision problems can be an early sign. This includes double vision and inflammation of the optic nerve, causing pain with eye movement and vision loss. Muscle weakness and tingling or numbness often occur in the arms and legs, but can include the trunk area and the face. Muscle stiffness and painful muscle spasms can accompany this as well as fatigue. These issues can be severe enough to affect walking and standing, and in some cases lead to paralysis. Clumsiness can occur, including intermittent or constant dizziness and difficulty staying balanced when trying to walk. Bladder control and constipation can also be issues. Oftentimes, MS can cause mental and emotional symptoms like depression, mood changes, and mental fatigue. Cognitive issues can include problems concentrating, multitasking, learning, or difficulties with memory or judgment. Women are more likely to develop multiple sclerosis than men. It is most common in Caucasians or those of Eastern European descent, but it does occur in all races and ethnicities. Although MS is not an inherited disorder, you are more likely to get MS if you have immediate family members with MS. There are hundreds of gene variations that make one vulnerable to MS. Viruses like Epstein-Barr virus are linked to the development of multiple sclerosis. Those who smoke are more likely to develop MS with a more aggressive progression. They tend to have more brain shrinkage and lesions than non-smokers. Another risk factor is not spending much time in the sun and having low levels of vitamin D. Research shows people who spend more time in the sun have relatively higher levels of vitamin D and are less likely to develop MS. When it comes to diagnosing MS, doctors use different tests to confirm the diagnosis. MRIs can be ordered to look at the brain and the spinal cord to identify the common lesions of MS and may involve using contrast to enhance images. Another test is the lumbar puncture. The cerebrospinal fluid is examined for proteins and inflammatory cells associated with MS. Evoked potential tests involve electrodes being placed on the skin and sending painless electric signals. This measures how quickly and accurately the nervous system responds to stimulation. Other scans of the optic nerves, like optic coherence tomography or OCT, can detect optic nerve lesions. As always, a complete medical history and physical exam is performed as well as a detailed neurological exam. There is also the Kurtzka Expanded Disability Status Scale, which measures the disability status of people with MS on a grade scale of 0 to 10 in half-point increments. A link to download the Kurtzka EDSS form from the National MS Society is provided on this slide. There is no cure for MS, but the treatments can lessen the number of releases and delay long-term progression. One of the most popular treatments is the use of corticosteroids, which can be injected and taken orally and tapered. They aid in the recovery of the MS attacks, but doesn't stop long-term progression. Other treatments include infusion treatments, oral drugs, and other injectables. These can aid in helping reduce inflammation and the frequency of attacks, and they can also delay the progression of physical disability and development of more brain lesions. As we know, it is important to not code probable or suspected diagnoses as definitive diagnoses. However, if it has been established that the patient is experiencing manifestations of demyelinating disease of the central nervous system, codes from G36 to G37 code sets can be referenced. The ICD-10-CM index can be used to further specify the central nervous system disorder if the specificity is documented. Or you can use unspecified demyelinating central nervous system disorder, code G37.9. Some important codes for coding multiple sclerosis include that there is only one code for definitive diagnosis of MS, and that's G35. But it is always important to document severity and code any manifestations of the disease, including quadriplegia, polyneuropathies, weakness, or central pain syndrome. It is also important to spell out the diagnosis of multiple sclerosis instead of using MS the first time it is noted in the encounter, so that it is not confused with other conditions. Multiple sclerosis is an incurable disease that will not go away. Refrain from using history of MS and instead document that it is a long established condition that is currently present. Here we have another coding scenario. A 43-year-old woman presents with multiple sclerosis, but it is unknown whether progressive versus relapsing, remitting, based on symptoms and history. The MRI shows multiple lesions commonly seen in MS in the white matter of the brain. One other lesion is in the corpus callosum. What codes should be assigned? We would assign code G35, multiple sclerosis. Only the multiple sclerosis may be reported because there are no specific symptoms documented, but there is a confirmed diagnosis. Now I will pass it to my colleague Kira to talk about epilepsy and seizures. Good afternoon, Kira.
Good afternoon, Missy. Thank you so much. What is epilepsy? Epilepsy is a chronic brain disorder where neurons send incorrect signals causing seizures. During a seizure, excessive electrical activity in the brain leads to involuntary movements, sensations, emotions, or behaviors, and sometimes a loss of awareness. Recovery time from seizures is different for everyone and could be immediate or take several hours. Epilepsy has many causes and types. Some may experience convulsions and loss of consciousness, while others might have brief lapses of awareness. Seizure frequency also varies widely. Not all seizures indicate epilepsy. Conditions like first seizures, febrile seizures, non epileptic events, and eclampsia can involve seizures without necessarily being epilepsy. So, who is most likely to develop epilepsy? It affects people of all genders, races, ethnic backgrounds, and ages. About half of all people with epilepsy do not know the cause. However, some known causes include genetic factors such as inherited genes, de novo mutations, which are spontaneous gene mutations with no family history of epilepsy, and ion channel genes, which are variations in the genes controlling ion flow in and out of the cells. All of the gene types can increase the likelihood of seizures and how well anti seizure medications work. Other conditions that can lead to epilepsy are known as co occurring conditions. Once treated, they may no longer experience seizures depending on what part of the brain region is affected and how much brain damage was caused. This includes brain tumors, brain trauma or head trauma, alcohol withdrawals, strokes, bleeding or swelling of the brain, and infections. Other developmental disorders linked include cerebral palsy, autism spectrum disorder, or intellectual disabilities. As we have said, having seizures does not mean you have epilepsy. While seizures can be induced by triggers like stress, hydration, visual stimulation, and sleep deprivation, seizure triggers do not cause epilepsy. Seizures are a symptom, and epilepsy is a disorder. There are many types of seizures in epilepsy, and they do overlap. Seizures are divided into two broad categories: focal and generalized. Focal seizures come from one part of the brain and are named after the area of the brain they originate from. About 60% of people with epilepsy have focal seizures. In focal seizures, consciousness can be retained or altered. Auras also indicate an impending seizure. Post seizure symptoms include headaches and muscle pain and can be mistaken for other disorders. Generalized seizures can be caused by abnormal neuron activities on both sides of the brain, characterized by a loss of consciousness, falls, or massive muscle contractions. There are 7 types of generalized seizures, as you can see listed on the left. Some common types of epilepsy are listed on the right, though there are hundreds. Absence epilepsy includes lapses of consciousness caused by repeated seizures. Front lobe epilepsy is brief focal seizures in clusters. Temporal lobe epilepsy, or TLE, is the most common focal seizure in childhood and teen years. Neocortical epilepsy can be focal or generalized from the cerebral cortex. Childhood epilepsy syndromes include infantile spasms, childhood absence epilepsy, and others that can be difficult to treat. Any kind of seizure should be reported to your doctor because diagnosis is imperative to treatment. There are several tests that can be used to determine what kind of seizure a person has and whether they have epilepsy. Medical history, including duration of seizures and witnessed accounts, are very important since a person often doesn't remember what happened during a seizure. Imaging tests such as EEGs, CTs, MRIs, and PET scans can test the person's brain for abnormal electric activity, location, and whether or not any tumors or cysts are present. Blood tests for metabolic and genetic disorders and developmental, neurological, and behavioral tests can also be used to provide clues. Treatment can vary, but most often include anti seizure medications. Those who do not respond well to medication or diet and lifestyle changes can be candidates for surgery or using a neurostimulation device to reduce seizure frequency. Many people with epilepsy can do the same typical things as those without epilepsy. However, about 1/3 of people will experience symptoms that can impact their quality of life. Depression and anxiety are common. The risk of seizures can sometimes limit driving and the ability to participate in sports. By law in the U.S., people with epilepsy cannot be denied employment or access to education, although sometimes anti seizure medications have negative side effects that make it difficult. These medications can also impact pregnancy with increased risk of birth defects, but most can have a healthy pregnancy with good outcomes. Those who experience frequent seizures every day and are treatment resistant can have cognitive impairments or even sudden death. It is important to use the appropriate language to document seizures and epilepsy. Always follow the documentation to look up a code in the alphabetic index for seizure, convulsion, or epilepsy. While the term seizure alone is not classified as epilepsy, seizure disorder or recurrent seizures are classified as epilepsy in the alphabetic index. Without a definitive diagnosis of epilepsy, seizures, or convulsion codes from the R56 category should be used. For epilepsy, it is best to specify type, whether intractable or non intractable, with or without status epilepticus, and any contributing factors to code to the highest level of specificity. There are over 60 codes that risk adjust for epilepsy and seizures and fall into HCC category 201. Let's take a look at a coding scenario. We have a 21-year-old female. She presents with paperwork to reinstate her driving privileges. Originally diagnosed with absence epileptic syndrome when she was 19 years of age, her seizures are now well controlled with medication. Ethosuximide, she has been seizure free for the past 18 months. What code should be assigned? So for this coding scenario, the correct codes to assign would be Z02.4 for the encounter for examination for driver's license and G40.A09 for absence epileptic syndrome, not intractable since it states well controlled and without status epilepticus. Next, we are going to talk about neurological deficits due to strokes, also known as sequela of strokes. First, let's talk about the strokes themselves. Cerebral infarctions, also known as CI or CVA or strokes, occur when there is a loss of blood flow to part of the brain. The loss of blood flow results in brain cell death, which can cause lasting brain damage, disability, or death. Causes of the loss of blood flow include an ischemic stroke or clots, which occur when the blood vessel is obstructed from supplying oxygen in the blood. This is the most common and it accounts for 90 or 87% of all strokes. The hemorrhagic stroke or brain bleeds occurs when a weakened blood vessel ruptures. The most common cause of this kind of stroke is uncontrolled hypertension. If strokes or cerebral infarctions are not caught fast enough, they can cause deficits that result in disabilities such as hemiplegia or weakness on one side of the body. Here is a look at the most common neurological deficits related to having a stroke. These can be temporary or long lasting depending on the individual, whether it was caught early and or following through with treatments such as rehabilitation and therapies. Motor function deficits can include weakness or paralysis on one side or just one extremity, known as hemiplegia or monoplegia. Another extremely common deficit is difficulty speaking and understanding language. Difficulty swallowing or dysphagia can also be a significant issue. So, what determines the deficits of a stroke? We'll take a closer look at that on the next slide. When it comes to neurological deficits or sequela of strokes, there are some factors that determine what they may be. For example, if you have a stroke on the right side of your brain, it will affect the left side of your body, vision, and memory, to name a few. Stroke severity is also a factor depending on the size of the stroke or whether you have had multiple strokes in the past can determine more significant impairments. Individual factors such as age, health, and any pre-existing conditions can subsequently impact recovery from strokes. Those with other medical conditions such as hypertension, diabetes, and high cholesterol are at a higher risk of stroke And these conditions should be managed with medications properly to prevent another. While recovery is possible, it all depends on the person and the nature of the deficits. The biggest recovery can happen in the first 3 months and then slows down in the next 6 months. It will progressively slow even more after that, but small, subtle changes can still happen after a year or two. What we do know is that the earlier the rehabilitation, the better. Speech pathology can be used to improve communication and swallowing deficits, while physical therapy can help build back strength and muscles. There are also therapies for emotional and mental support. Having a support system, including family and social support, are also important in recovery time. Since we are discussing strokes, I thought it would be a great time to highlight our 2023 MA audit of 1,412 diagnoses of ischemic or unspecified stroke. We found that only 5 diagnoses were fully supported. So, a surprising 1,367 of those diagnoses were not supported, and 40 diagnoses were unable to be coded due to insufficient information. So that is a whopping 97% of strokes being coded incorrectly. Most diagnoses were coded as acute stroke when they should have been coded as history of. So, this is a common miscoded condition among providers. It is imperative to educate providers on how to code strokes in an outpatient setting. Next, we will highlight some key coding guidelines for stroke to improve coding documentation. Here is a way to look at 3 important stroke categories. The I-60 through I-63 codes are for acute strokes, strokes that are happening at present and are diagnosed in the hospital after thorough examination and testing. Here in the middle column is our history of TIA and stroke without sequela. This is for someone who comes in for an outpatient visit and reports that they have had a TIA or stroke, but there is no documentation of residual deficits. And the other important point to remember is that a patient experiencing no residual effects from a previous stroke should never be signed or assigned a current stroke code from the I-60 through I-63 category. And then here on the right is the description of the I-69 category, sequela of cerebrovascular disease. On the outpatient side, this is what we would expect to see coded. I-69 codes specify the type of stroke that caused the sequela, as well as the residual condition itself. Codes from category I-69 also identify whether the dominant or non dominant side is affected. Let's take a closer look at the I-69 codes. This is a summary slide of the I-69 codes. You can see there are specific codes for each kind of stroke. For instance, in the first row, you see I-69. These codes are for sequela of non traumatic subarachnoid hemorrhages. You can see most of the codes in this slide are for subarachnoid strokes or hemorrhagic strokes, except for the bolded row in the middle, I-69.3. These are the sequela codes for an ischemic stroke or a stroke caused by an occlusion or stroke that is unspecified in type. An ischemic stroke is the most common kind of stroke. Over 87% of all strokes are ischemic. according to the National Institute of Health. If you look up stroke in the alphabetic index of your book or encoder, you can get a list of the sequela to check in the tabular list. Remember, I-63 is for acute stroke being presently diagnosed. We want the I-69 sequela codes. You must click on sequela, then scroll down to stroke. Once you follow the link or path in your book, you will find all of the deficit codes for each type of stroke. The list is too long for a slide, but for every kind of stroke, there are many deficits listed. So once you have chosen the deficit, you must go to the tabular list for verification and laterality. Let's choose hemiplegia I-69.35. And just a note, these codes are the codes for sequelae of an ischemic stroke or cerebral infarction. Please reference ICD-10 CM coding resources for the categories listed in the yellow box if sequela was caused by hemorrhagic strokes or cerebrovascular disease where an infraction has not occurred. Once you've chosen hemiplegia, now you need laterality, and you must code whether the dominant or non-dominant side is affected. The guidelines tell us codes from the category I-69 sequela of cerebrovascular disease that specify hemiplegia, hemiparesis, and monoplegia identify whether the dominant or non-dominant side is affected. Should the affected side be documented but not specified as dominant or non-dominant, code selection is for ambidextrous patients. The default should be dominant. If the left side is affected and there is no documentation that the person is left-handed or right-handed, the default is non-dominant. If the right side is affected and there is no documentation, the default is dominant. So let's practice. Our documentation states right-sided weakness in a right-handed person. The code would be I-69.351, hemiplegia affecting right dominant side. Now, if the provider wrote something in the notes that a left-handed individual had right-sided weakness, then the code would be I-69.353, hemiplegia affecting right non-dominant side. Here is our last coding scenario for the day. We have a 58-year-old male patient presents for follow-up in the office 7 days after being discharged from the hospital due to a cerebral infarction as a result of stenosis of other pre-cerebral artery. He presented to the hospital initially with left arm weakness. Upon exam, patient still has residual weakness in left arm with 2/5 for strength. So the correct assigned code for this scenario would be I-69.334, monoplegia of upper limb following cerebral infarction affecting left non-dominant side. The provider did not document which arm is dominant, so the left arm defaults to non-dominant. So now I will hand it back over to Jackie to conclude our time together.
Thank you, Kira. Thank you, everyone, for joining our educational webinar today. We appreciate your time and hope you found this session informative. We would also like to remind you that we offer personalized risk coding training tailored to your needs, whether you prefer virtual sessions or on-site trainings. Please use the QR code provided here to give your feedback on today's presentation. Also, if you're interested in personalized training, Scan the QR code to show interest. Our CEUs will be emailed out along with a copy of the webinar deck. A big thank you to our speakers, Missy Leggett and Kara Cheek, for their contributions today. We look forward to seeing you at next month's webinar, Risk Adjustable Vascular Disease Coding. For more information about upcoming webinars or personalized training sessions, please visit our external site using the provided links. This concludes our webinar. Thank you again and have a wonderful day.